Okay, thank you very much, Jerry. This is going to be very short. I'm just going to introduce a couple points I want to make. This is by far the most important. We have to, assuming you don't have, assuming your administrator is not telling you, please put in as many devices as you like, you might have a restricted access to the number. And I believe that we should be putting those devices into the patients who are most likely to respond very favorably, and I think that's essentially the most important part of the message. Just to remind you of a couple very small things that you're all aware of. I think that left bundle branch block is being increasingly defined, and I was reading some papers yesterday where it's almost a cardiomyopathy. It wants to get its own definition. The presence of left bundle branch block I look at as almost a malignancy for the left ventricle, in terms of the time it takes to eject and the manner and the desynchronous way that it ejects. And I think that we've got to pick up those patients. And I think that usually we should be trying to pick up those patients prior to admission to hospital. We should be picking them up in the outpatients or through referral from primary care. And that's what I believe is very important to emphasize. I want to remind you that it's not just the delay in the left ventricular activation or the dyssynchrony. It's what it does to volumes. If you see the one on your right, it's larger than the one on your left. And we know that if you want to pick out who's going to be alive or dead by Christmas Eve, the best way for you to do that is to divide those patients, categorize them according to volumes. Big volumes are bad news and are a powerful negative prognostic indicator. This is an example of an individual meta-analysis that was performed. I'm sorry the reference is not here. It was 2 years ago, QRS. First author, John Cleland. This is all the Medronic trials, and it's a bootstrapped analysis in which you look and you can see that at somewhere around here, if we just look at the mortality, heart failure, hospitalization endpoint, which is a strong endpoint. Somewhere around here, the confidence interval no longer crosses the line of unity. So we see that significance is occurring right about here. And if you move in from the 140, 150, the 160, you get a very strong response for these two most important morbidity and mortality endpoints. I want to remind you that there might be a difference in your decision to implant a CRT-D with a defibrillator component or not. This is a paper that was published last year in our journal, and you can see that the difference between the separations for survival between patients for CRT-P and CRT-D are very different, but they were not for CRT-P in non-ischemic cardiomyopathy versus ischemic cardiomyopathy. Sorry, I forgot to say that. This is not a randomized trial. This is a very large center of consecutive over 800 patients that were selected according to the clinician's decision. But I think that it's important to realize that not everybody who requires a CRT should be getting a D, and we could perhaps discuss this later. In response, which I think is something that is a term that's being used a lot, I think it's unfortunate that we're still talking about a 30% lack of response rate. I think those patients were poorly selected. Perhaps the lead placement was not optimal, and perhaps the follow-up. So this is a very nice paper that you might want to look at from Vitta et al. That shows the different ways, we're very hard on devices. The bar is very high for devices in terms of saying who responds and who doesn't respond. So if we look at, let's say, quality of life over time, we tend to say, well, if it doesn't go to 1, then it's non-response. And I disagree with that. We certainly would not say that for drugs, and to ask a device to only be restricted to 0.1 is not really fair. You can see that this patient does not deteriorate. That's a good response. This patient deteriorates slowly, but doesn't deteriorate as rapidly as the other patient. This is the non-responder here. So I think that there are different ways, and if you're interested in this and you like the philosophical arguments that are put forward by these authors, you might want to read that paper. I found it, very interesting. I just want to stop by saying that we did do a survey earlier that showed us that things were very surprising. The difference between the recommendations, the guidelines, and the clinical practice was surprising. We had patients, these are patients who are not involved really in clinical trials, and yet this is what we were doing. A third of the patients were over the age limit for what we had experienced with, although we know that these patients are important to implant. 20% were almost very mildly symptomatic, and we had no data at that time. A quarter of them were in AF, and I think we're learning more and more about how you've got to make sure your patient is getting the therapy, and you've got to make them pacemaker dependent, probably by ablation, before you put these into that. I'm sorry about the mouse, but it seems to be uncontrollable. We had very narrow complex, and under the 120, I think that's been answered pretty well by the analyses and the meta-analyses. And on Monday, there is a publication which is coming out simultaneously with a hotline at this meeting, which goes to the 120-130 interval from echo CRT. And you might want to look at that paper if you're interested in those patients with mildly prolonged QRS complexes. And also, I think this is the big group that's going to increase, as we've understood the negative effect of pacing in these patients and what this does. It produces a left bundle branch pattern, wide complex, and dysynchrony. And are we going to truly follow up these patients adequately, or should we be putting devices in prophylactically or waiting for deterioration? So my final slide just reminds you that if any of you are implanters here, you're going to be asked to participate in a very successful, hopefully a very successful new survey, short snapshot that's going to run from September 1st this year. And you can see a lot of it's truly a cooperation between ERA and HFA. And we do hope to be able to find out what patients are really doing. I'm proud to be able to say that we've recruited national coordinators in 46 out of the 47 ESC member states. So we hope to be very representative. So in this session, I think there'll be issues that are going to be taken up. I've understood that we agreed to take questions after each talk rather than the panel. And I hope that we do address some of these important issues for such an efficacious therapy. I think all of us who have that anecdotal experience see the patient who changes a function class. It's very gratifying. So let's make sure we're choosing these patients, picking them out, identifying, and implanting them optimally. Thank you very much.